Stop sharing the screen.
Yep, and then I'll you go ahead and get started, and I'll try to find the screen and the presentation, and we'll go from there.
Okay, so sorry everyone that we're having such trouble today. My name is Nikki Davis. I am the Director of Patient Financial Services at MetroHealth. I've been with MetroHealth for 19 years. And I am part of the front end of revenue cycle as well as the back end, where we do all the billing and collections. And I am also the chair for Ohio Health Association Admitting Billing and Collections Committee. Marianne?
Yeah, hi everybody, I'm Marianne Oschlager. Really good job pronouncing that, by the way. In August, I celebrated 23 years in the revenue cycle at MetroHealth, and I'm currently the Director of Revenue Cycle Operations. I am fortunate to manage a wonderful team of 2 supervisors and a manager that are responsible for the cash application and the Rapid Reg departments. We'll tell you a little bit more about Rapid Reg later in our presentation. We also lead Cashier's Office, which reconciles the cash collections throughout the system. Lastly, we oversee the customer service advocacy team as it relates to all billing inquiries, the self-pay AR, and bad debt collections. Nikki?
So I'm not sure what you all are seeing yet, but the first thing that we wanted to do was give you a little bit of an overview of our hospital. MetroHealth is located in Cleveland, Ohio. It is home to Cuyahoga County's most experienced Level 1 adult trauma center and Ohio's only adult and pediatric trauma and burn center. As an academic medical center, we are committed to research as well as to teaching and training tomorrow's caregivers. Our physicians hold a faculty appointment at Case Western Reserve University School of Medicine, and our hospital houses the Cleveland Metropolitan School District's Lincoln West School of Science and Health. It is the only high school in America that is located inside of a hospital. At MetroHealth, we have 4 hospitals, 4 emergency departments, 33 ambulatory sites, and 10 pharmacies. We employ over 630 physicians, almost 7,900 employees, and service over 150,000 unique patients with 1.3 million visits annually. We are redefining healthcare by going beyond medical treatment to improve the foundations of community, health, and well-being. We seek to improve affordable housing, a cleaner environment, economic opportunity, and access to fresh food, convenient transportation, legal help, and other services. The system strives to become as good at preventing disease as it is at treating it. Our future named MetroHealth Click Center will be an 11-floor hospital, which is currently under construction on our system's main campus. We are scheduled to welcome our first patients in October 2022. This billion-dollar project is the cornerstone of a wider neighborhood revitalization effort led by MetroHealth and its partners in the community. Next slide, please.
Artificial intelligence is not just part of the revenue cycle. It can be implemented across your entire organization. The vendor we have chosen to partner with offers several artificial intelligence solutions, not only across the revenue cycle spectrum, but in supply chain, pharmacy, finance, as well as HR and clinical operations. However, since Nikki and I are from the revenue cycle, the area we are focusing on for this presentation is related to how we implemented AI from the aspect of check-in procedures and registration as it relates to billing. While registration is the main focus of our presentation, we are also exploring proven AI technology for prior authorization and for the claim status process, with the hopes of leveraging this technology later this year.
Hey, Jennifer or Marianne, can you guys try to showcase your slides again? I'm struggling finding them myself. Show your screen again, Nikki, if you don't mind.
Sure. I will try one more time.
All right, we see them. We're on number
Okay,
5.
let's hope I
Is
can
it forwarding?
move forward. Okay. But I'm frozen again. I can't move forward on the PowerPoint.
Are you logged in outside of the VPN again, or are you in the VPN?
I am out of the VPN.
I guess go in and keep coming back out to each slide, because now you're at 5. So until I can find the slide deck, or if you want to email it to me real quick, one of you guys.
That might be faster.
Yeah, go ahead and email it to me, and then you guys keep going on with your presentation, and I'll just pull it up.
Okay, so what our slide is currently showing right now is the return on investment of AI for revenue cycle. And in general, AI offers a range of return on investments across a healthcare organization. Whether your return of investment focus is on net revenue or other areas such as patient and employee satisfaction, you should see a benefit to your bottom line. Here at MetroHealth, we are benefiting in net revenue by not only having the correct registration at this time of service, which is giving us reduction in registration denials, but we're also benefiting from charge capture to ensure payer-specific coding guidelines are met. We also have seen an increased accuracy and time of service collections, which are resulting in a reduction of our statement expenses. AI has allowed us to manage our back-end labor cost by reducing overtime and outsourcing expenses. Our staff no longer have to work beyond their 40 hours a week. So we have seen an increase in their employee satisfaction by promoting a better work-life balance. Our front-end staff is also satisfied since they see more accurate verification of registration at check-in and saving them the task of running real-time eligibility and updating coverage at the time of the visit. Mary Ann?
MetroHealth is a county subsidized hospital, so we are required to submit a request for proposal when seeking external partners. The benefit of this RFP process allows us to outline specific criteria. When MetroHealth went to complete the proposal for AI, we chose to focus on 3 major objectives: patient-specific tasks, artificial intelligence, and the technology partner. Let me explain a bit more what this meant to MetroHealth. First, we focused on patient-specific tasks. MetroHealth was seeking a partner that had the ability to assist with scheduling, eligibility verification, authorization management, patient out-of-pocket expenses, and the ability to support the billing and collections as it relates to claim status. We were also interested in any possibilities that were available through discovery. Our second focus was on artificial intelligence. So it's page 7, there you go. Our second focus was on artificial intelligence. MetroHealth was interested in a partner who could develop workflow functionality that would automate and orchestrate repeatable processes. Additionally, the partner was expected to have functionality that supports easy creation, assignment, and tracking of tasks to ensure that all were carefully managed throughout the organization. MetroHealth also sought billing and prior authorization functionality that would improve the timeliness and accuracy of MetroHealth's service delivery and accurately track the effectiveness of the artificial intelligent assistant while being HIPAA compliant. Lastly, MetroHealth focused on the technology partner. We were looking for a technology partner who would work alongside and in collaboration with various teams across MetroHealth. This meant the partner took on the overall management, supervision, and administrative support for all activities performed by AI, the configuration, testing, and implementation of, and the AI assistant was also the responsibility of the partner. At MetroHealth, once a vendor is chosen, a service level agreement within the contract is negotiated. This service level agreement involves a bonus and/or penalty that is based on performance. The service level agreement is mutually agreed upon prior to the contract finalization. Next slide, please.
So right now, you should be looking at the 17 steps needed for the insurance verification process MetroHealth had prior to AI. This looks simple, right? How many of you all have had a process as convoluted as this? Our operations department's feedback was that they are challenged in keeping check-in lines at a minimum to increase overall patient satisfaction. The front-end staff often perform the verification process in between patients or during their downtime. However, it was unlikely to verify each visit prior to the date of service, which then caused a delay in the check-in process at the time of the visit. It seems counterproductive to aim at increasing patient satisfaction only to decrease it with a process as convoluted as this. So there had to be a better way. Next slide, please.
So the better way we found was in collaborating with operations here at MetroHealth and Olive, the AI partner that we chose, to bring those 17 steps down to 9. The icing on the cake is that those 9 steps in most cases do not need any manual intervention by staff. Our new process includes MetroHealth sending a daily extract of the upcoming scheduled visits to Olive. The data includes patient demographics and insurance data for all coverages on the visit, whether in the primary, the secondary, or the tertiary position. Based on the information in the data extract, Olive pings the payer web portals for eligibility. Before marking any patient as self-pay, Olive will ping the Medicaid portal for eligibility since this is not considered phishing. This extra step is beneficial since we never want to bill a patient if they qualify for Medicaid. After Olive verifies the eligibility status, she compares it to the data in the extract. If no changes are found in the primary, secondary, or tertiary coverage, Olive then marks it as verified in the visit in Epic. If a discrepancy is found, Olive will make necessary updates such as editing the subscriber ID or the effective dates directly in registration. While this process addresses the majority of eligibility verification, Olive is still not a human, so exceptions are flagged for manual review at check-in. Next slide, please.
Getting the staff comfortable with the idea of AI wasn't that difficult for us at MetroHealth. Since the AI processes occur before the visit, we really didn't need a buy-in for front-end staff as it was transparent to them. Since the majority of the verification is completed before the visit, the check-in staff have fewer accounts flagged for manual intervention. Not only is the check-in staff happier since AI has made their job easier, but it also lends to a better patient experience. Through this presentation, we focused on how AI enhances the front-end workflows. Let's talk about how it can help with other areas. A few years ago, we realized that the front-end staff could not capture correct registration all the time. So we created a team called Rapid Registration as part of the back end of the revenue cycle. This team is responsible for reviewing all registration errors after the visit. Since the implementation of AI, the coverage is verified and updated prior to the visit. Therefore, we're seeing less errors on the back end. This allows the Rapid Registration team to focus their efforts on more difficult tasks that require critical thinking skills. Considering most of our workflow changes were transparent to the staff when we started this journey that led us to AI, there was no need to involve the staff. We did not share with the staff that we were looking to automate the repetitive actions that they performed daily. So ultimately, they never even considered it a risk to their job security. Next slide, please.
If you're worried about the staff allocation and implementing AI at your facility, as you can see, Olive really did most of the heavy lifting, doing more than half at 58%. I'm not sure how it is at your organization, but here at MetroHealth, we are always juggling several priorities at a time. Therefore, From the beginning, we let Olive know that due to the constraints we were experiencing, it prevented us from doing most of the work and that we had to rely on them. So much so that we included that in our contract. With some initial assistance from operations, the revenue cycle had a big part in identifying the workflows, but it was the responsibility of Olive to create the workflows that utilize AI. It was also the responsibility of Olive to do the initial testing, fixing any issues found, and then retesting. By Olive taking on the responsibility of testing the workflow, the revenue cycle only needed to dedicate their time, approximately 28%, by confirming data accuracy. Again, not sure how your organization is, but here at MetroHealth, our information services resources are even more restricted than the revenue cycles. Relying on Olive permitted us to keep their involvement as limited as possible. The IS department was responsible for building the Epic work queues and assisting with the file transfer process, taking approximately 14% of the work effort. Next slide, please.
If you are worried about getting payers on board with AI, at MetroHealth, the way that we designed our workflows, it was just as transparent to our payers as it was to our staff. MetroHealth gave Olive multiple employee sign-ons. These employee sign-ons allowed Olive to have direct access to the payer portals, performing the same task as a human. Again, keeping it transparent to the payers. Next slide, please.
So for our last slide today, we'd like to close with MetroHealth's return on investment. Quality is achieved based on efficiencies, productivity, and accuracy, as we all know. By implementing these eligibility bots, it has the human power equivalent of 42.7 full-time employees. Before implementing artificial intelligence at our pilot site, the accuracy of eligibility rate was 51.55%, representing about $22 million in charges. After implementing AI at our pilot site, the accuracy eligibility rate was 93.2, representing $58 million in charges. Now that we are live with all our sites, our accuracy of eligibility rate is holding at 93.3%, representing $454 million as of September 2021. If we annualize that, it will be $1.82 billion in charges that will have accurate eligibility. Next slide. Questions?
I'm looking in the Q&A to see if there's any questions, and I do not see any. However, we know that those may come later on.
Feel free to pass them on to Nikki and I.
All right, I will. Nikki, Jennifer, thank you very much. We appreciate your presentation. Sorry for the technical glitch, but we will get that fixed. Now, we will bring to you, and we are going to bring to you, our panel on capacity management. And rather than my introducing all of the speakers, our panel moderator, Mr. Elbridge Locklear, again, the CIO from MetroHealth, will take care of those introductions. Elbridge, I turn this over to you and the panel, if the panel's here. Okay, give us 5 minutes to get ourselves together here on the panel, and then we will bring it to you. Hi, Elbridge. How are you?
Good, good. How are you doing?
I'm fine. We have our moderator, guys, so we're making progress.
I want to apologize. I'm trying to move around. The sunlight has really moved around here, and that set me off there. Okay.
Hey guys, can you hear me?
Yes, we can.
Yes.
Oh, great. How's everybody?
We're fine. We're fine.
Hi, Elbridge. Nice to meet you.
Hi, Brad. How are you doing?
Doing well.
I think we've got a couple other people joining. We'll give it just a moment. All right, we got Dr. Kluatjy with us. We've got one other person joining, Jeff Bendino. We'll give him just a moment, and then we'll get started. He'll probably join part of the way in. We'll give it till 10:46, and we'll get started. I'll tell you what, I know we're waiting for one other person to join. I'm going to get started and start with just kind of some ground rules, that sort of thing. So first of all, I want to thank all of the speakers today for sharing all of their insight with this group of individuals that really care about healthcare as a whole. So thanks for your time today. And then I wanted to restate a couple of ground rules that Christine indicated earlier. I've asked all of the speakers to actually speak their name, title, company, and a short statement of their responsibility before they answer the first question. Number one, I want to take a quick look back for the speakers, at least the panelists today, and say, consider all of the presentations if you've had an opportunity to see the presentations today. And what we found is that from a capacity management perspective, there really isn't an easy answer, right? There's a lot of considerations. There is no easy button. So we're thinking human capital, technology, physical real estate, customer devices, security, timely data, accuracy. There's just a ton of different things that are necessary to meet the capacity needs today. And I want to start with a statement I want you to consider before you start to answer the questions. As you all know, COVID-19 experience has changed our day-to-day operations in all industries. Many leaders believe that the operations will be a tech-driven model going forward. And a couple examples I want to share with the group, and I'm reading a couple of statements. So, in the restaurant industry, full-service restaurants increased use of web mobile orders from 5% to 33%. Now that's dated information over a few months, but just consider that usage, just jumping to the use of technology to the fullest, even though that is something that has been on the docket and restaurants have been trying to achieve for a while. Another statement, in the healthcare industry, the use of predictive analytics for COVID tracking has become a complete necessity, and it works. The use of wearable medical devices for proactive medical care has become a must. And a lot of health systems are really trying to figure that out, right? So what we've learned is that the experience from COVID-19 has forced many industries to invest in technology to improve service and create better efficiencies as a whole. And this experience has changed many of our daily priorities. So I think I'm going to get started here. So I'll start with the first question, and I'll call out the first panelist. Jeff, thanks for joining us.
Sure. Hi, how are you all?
Good. Just in time. I've asked everyone to state their name, title, organization, and a small statement about who they are when they answer the first question. We're about to start with the first question. So We'll start with Dr. Kluatjy. What new operational priorities have emerged in your space to deliver product and services, and why?
Hi, Elbridge. Can you hear me?
Yes, I can.
Okay, great. So Stephen Kluatjy, I'm an invasive cardiologist. I'm also Senior Medical Director of Digital Health here at Summa Health, with a goal to try to improve patient engagement in our system using IT and working with clinicians to do that. So, the first this issue of operational priorities, you alluded to it, I think earlier when you mentioned that there are really not one thing, not two, not three. It's really a wide variety of tools, a wide variety of priorities that we're going to have to address to be able to make this worthwhile. And I think Lucas's talk, touched on that with a number of different parameters, a number of different locations in the ambulatory setting, where you can try to address one issue, but really there are others. So the issue that is most immediate to Summa Health right now is related to the fact that we are going to have a decrease in the number of hospital beds. That is going to drive operationally a significant change in the outpatient space. And those messages have already gone out to the entire clinical staff, which is, if patients are not going to have beds available, we're going to need to do a much better job in the outpatient setting to address questions, and instead of having them go to the emergency room for one thing or the other, or even allow them to do that on their own. It's really a matter of educating and understanding our patient population. So I think I would start with that. I think one of the things that we're not really doing and have not done very well is that we've not understood our patient population. We have not been able to educate them on the tools that they need to interact with us most effectively. We talk about patient engagement. We talk about my chart. We talk about, just give us a call. But we've not been very good at being able to help them navigate that process. And I think that's going to be an important starting point to address these issues operationally, just in terms of essentially boots on the ground to be able to make this work. Less work in the hospital means some of those providers are going to be shifted to the outpatient setting. So operationally, that's one of the things that we're seeing, is that we're going to be pulling some of those providers that were historically covering the hospital, pulling them into the office. So I think that's what I'd say about that.
Thanks, Dr. Kluatjy. I think I'm going to go to Lucas next. And again, I'll restate it. What new operational priorities have emerged in your space to deliver products and services, and why?
So a lot of them I pointed out, I think, during the talk, but the biggest priorities are in my current space right now in the ambulatory world, is to better utilize the physical space and also better utilize staffing. I think there's a national staffing shortage right now, especially with MAs, clerical registration staff, as well as, like I said, the physical space that we need to use to get patients into. So if we can better utilize the technology and just different services and hardware in the office, the kiosks that take the place of a physical staff person, we can replace 3 registration staff members with 2 kiosks in an office. We can lose 20% of the square footage in a space just by downsizing waiting rooms and eliminating 10% of our exam rooms. So again, by utilizing some of these different technologies, different vendors, different products, we can meet meet those demands and meet those priorities, which we otherwise wouldn't be able to. I mean, we have to be able to start using technology, especially with the staffing issues, because there's not people to fill jobs. We have practices that we're not able to open because we don't have staff for them, and that's a significant issue when there's a need in the community for a medical service, and we have the ability to provide that service if we had base level staff members, which we don't have. So where can we use technology to help fill that gap? And we're always going to need people, right? Don't get me wrong. There's always going to be that necessity, but if we can use technology to assist in that and fill that gap, I think we need to try to do that.
And Lucas, you didn't get an opportunity to introduce yourself. Do you mind introducing yourself, company, and what your responsibility is?
Sure. Yeah. So sorry, Luke Smith, and I'm with MetroHealth System. My title is Director of Ambulatory Services and Property Management. So, my job is strategic growth of our ambulatory business, as well as just the day-to-day operations in our ambulatory centers. And with the property management piece, that's from the operational day-to-day, as well as, planning, design, building, and opening of ambulatory centers.
And I think you got that question repeated a couple times. So I'll let you get started.
Sure thing. So good afternoon. So my name is Jeff Pendino. I'm the Chief Administrative Officer for Go Health Urgent Care. We do joint venture partnerships with large health systems around the country. And my role is to support our billing and our analytics capabilities within the company. So if you look at operational priorities, for us, over the past, I would say 18 months or so, things have changed, pretty quickly with the pandemic, and even I think going forward, and it's accelerated virtual care, primarily where we've gone to a more virtual environment with urgent care over the past 18 months or so. And that's, posed a lot of challenges, both on the technology side and on the billing side, because things were changing pretty quick. Our process has been that we sort of had our toe in the water with virtual care a little bit. But the fact that we have bricks and mortar, but we also needed to be able to do that virtual piece was a huge piece of being able to scale up across. We have 7 partnerships and almost 170 plus now centers. So that was a pretty large lift, and the demand on a lot of the teams, both on our IT team and then on our billing team, to be able to get all of that set up and to be able to code and get claims out effectively was a big deal. The other piece that we've seen too is that there's been a lot of activity, at least with the pandemic, with direct to employers, where employers have reached out and needed support from centers that they don't know how to deal with individual patients or individual mandates around what they need to do as far as testing and some other things. So it's just supporting the communities and some other things have been sort of a large scale implementation across many different aspects of what we do.
Thanks, Jeff.
Sure.
So Brad, I'm going to go to you next, and I know you probably cringe at some of the things you've heard today, but it's going to be interesting to hear from your perspective, your priorities. What has changed in your day-to-day operations and why?
Yeah, thank you, and I appreciate you guys having me on this panel. And what I'm hearing is we're taking the physical world and tapping into the digital world a little bit to address some of these capacity management issues. And while Elbridge is mentioning why I'm cringing, that's a lot of data flying around. And I'm a principal of our advisory, which we're really on a mission in the cybersecurity space to help just simplify the path to security and compliance, so that we can enable some of these things to happen. So we do this through things like really 2 things. One is on the audit and compliance side. So we have services such as ISO, SOC, HIPAA, HITRUST, et cetera, and the rest of the alphabet soup of the reporting frameworks out there. And then the other is through Chief Information Security Officer services. So just really supporting the CISOs out there to get their heads wrapped around all these changes. And cybersecurity at its core is about humans feeling safe and protected, and I think safety and everything that we've been talking about today creates that trust in the marketplace. So the challenge 10 plus years ago was to get cybersecurity a budget and a bullet point agenda in the boardroom. And, now that's a key thing that we're talking about today. So spending on cybersecurity is up, but so are the data breaches. And so the challenge now is the transparency and educating the market to just make better informed decisions about what does this cybersecurity mean in our interconnected world, as we're hearing about all this data flying around from kiosks to connecting EHR systems to how that gets into the actual service. And there's a lot of lemons out there when it comes to pushing product out that I don't think we're doing a great job as an industry to educate, to allow the market to educate themselves on how to differentiate between a lemon as in a tool to solve these problems versus something that actually really addresses it. So, what we're seeing from priorities is getting that better visibility and transparency, and we're doing that through security and compliance automation. From a tech standpoint, Haroon alluded to this earlier in this presentation, that technology is outpacing regulations, and I don't think that's going to change ever. The intention behind the regulations are sound, but the speed of innovation is really just limited by what's possible. And so if we want to have more efficient capacity management, I think of in the physical world, if technology is really there to create that friction-free transaction, but we can't just set it and forget it. It's the constant relationship that we have with technology. And for example, we have these special transactions when we go to the doctor's office that we get handed this dreaded clipboard that requires us to complete the same 8-page health questionnaire that you must have completed dozens of times in previous visits. And you're asking yourself, haven't I already completed this information? Shouldn't it already be in the health system? And that's true. It's just, how do we untap that information so that's more readily available across the ecosystem? And things that we're doing with that, and I can talk about later, is just through the compliance automation partnerships that we address, that takes compliance and pushes that to a baseline, and so that people can focus more on the evolving threats that's happening in the cybersecurity space. So using compliance as the language, not the end goal. So compliance is just that baseline. Then, so you can communicate, hey, I have this innovative tech product, and I can talk about some examples of some of what our clients are doing. It's unbelievable that what they're doing of getting from zero to compliant within a matter of weeks, not months or years. But that's just the starting point. That's the table stakes so they can put their product to market to solve these problems. And then you can get to the real security aspect of it. Security can equal compliance, but compliance doesn't always equal security. And I think that is just how we really start to put trust in the marketplace, and then transparency across the board.
Thanks, Brett. All right, I'm going to move to probably my favorite question here for the group. What digital innovations, and we're thinking RPA, machine learning, artificial intelligence, are top of mind and most important for you in your role, either at your organization, could be at your organization, and why? Doesn't have to be just an RPA or machine learning or AI, but what's top of mind for you? And we'll start with Dr. Kluatjy.
So that's a good question. Top of mind. I think the things that I can see immediately showing benefit for us are probably machine learning tools. I think coming a really close second is an implementation of a robust AI solution. We have, for example, at Summa Health, the JVon project up and running. And I think that AI tools like that can satisfy a space, a niche that machine learning does not help with. And I don't think we use enough machine learning to move through the processes that we have. I think there's an opportunity there.
Thanks, Dr. Kluatjy. Lucas, I think I'm going to go to you next.
Sure. So for me, kind of along the same lines, right? It's the AI or ability for logic. In medicine, it's never cut and dry, right? No two cases are exactly the same. So to build a program that's specific to a specific case, there needs to be some type of flexibility right there, right? Or a way to adapt or logically, pivot a little bit based on the data that's inputted. I feel like so. That's something we've worked with a lot of vendors on, and that could be something as simple as I talked about asynchronous telehealth visits, right? Based on the way you answer this question, you should then get the following question. Those are what our providers do in office every day. So we need to have that AI or that logic built in place so that people aren't answering nobody wants to sit down and do a 30-minute questionnaire just in order to get the provider the information they need. But if you've got the AI and logic, you can get a provider the information they need in a 5-minute questionnaire. And just expand that out to other things too, like remote patient monitoring. If it's not an immediate feedback to a provider, you need to have that AI built in that if it picks up something that is concerning, that there's an alert sent to somebody that will look at it right away, or an alert to that patient that says you need to go to the emergency department, right? So that there's not just this data sitting out there that might be something alarming or something that needs addressed that's not. So those are the biggest things that I see.
Thanks, Lucas. Mm-hmm. Jeff, we'll go to you next.
Yeah, so for me, a couple things, and actually sort of in two different areas. So from a machine learning and AI standpoint, there's some really interesting some things. And actually, there was a talk that I saw at HIMSS back several years ago that really stuck with me, was that to be able to use AI and volume prediction as a staffing piece, or to be as a staffing tool. And, so we've really, jumped into that and looked at, some ways to be able to predict, especially during the times where you've got a lot of variation, is to be able to use the ability for the machine and some outside, factors and our own inside factors to be able to determine what do volumes look like 30 days out, or how do we staff to what we may expect in the coming months or weeks, or even sometimes intraday. To be able to know, where to send floater, staff members and things. So that's been a really interesting area of exploration that's started to yield some really interesting and better than, I would say, a person being able to try to set schedules like that. The machine learning has given us a lot more intelligence around that, from an analytics standpoint. And then on the RPA side, I'd say that there's a lot of talk these days around RPA within revenue cycle, because there's a lot of repetitive processes within revenue cycle. I've looked at probably 3 or 4 different vendors on types of RPA and how they approach it, and I think there's differences around how they go about teaching the processes to the bots. And there's different approaches from different companies on how that works, but it's definitely an area that is that there's several things around claims statusing and some other things within revenue cycle that are really repetitive, that are easily picked up by RPA. So those things seem like natural ways to be able to implement that. We've also looked at what does it look like to be able to take repetitive registration processes or some other things that are really that are really more straightforward and be able to turn that over to a bot maybe overnight and be able to turn a lot more productivity back the next day. So really interesting areas that we've explored.
Thanks, Jeff. I want to say one thing before we go to Brad. I know he's going to give me a totally different perspective, but I've had mixed emotions given seeing the presentations today, and as we've gone in and hearing from Dr. Kluatjy and Lucas and the other presenters. And I've always believed that technology is always ahead of healthcare. Technology is always ahead. Hey, let's get it figured out. But given where we're going today, I'm mixed emotions about it. I've heard so much about capacity. I mean, are we moving faster than the technology today? It's questionable. This is positive, what I've just heard on this question here, but I got to question that. So Brad, I'll turn it over to you.
I think that's a great point. I mean, I think the ideas are out there, and maybe we are moving a little bit faster than the technology can handle that. But that's where I think we can do a better job from a technology wise. Let's think of the when you said that, I think first of mind is just how we're handling credentials and trust, and how we're zero trust is such a buzzword these days, but it seems very old school the way we handle credentials. You got a password for everything. When it's kind of the original question about AI, and there's so many great technology tools that we just haven't really brought in more mainstream that can just recognize behaviors of how people interact with these systems and technologies to address all these problems that we're talking about today. It was a lot of it earlier was mentioned about ransomware. That's a big thing, but a lot of these ransomware attacks start with compromised credentials, and multi-factor authentication would help that. But today, the way we do multi-factor authentication is a little bit cumbersome to the end user, and you're always going to find workarounds. And so I think that having continuing to, I guess, use that buzzword of zero trust is being able to recognize how systems are intended to be used and learning about that with the way resources are being used. Gmail is an example from a resiliency standpoint. If you've ever used Gmail and you've been on a slow connection, it reduces the resource load, and it changes it into this very limited, stripped down HTML page. But that's so you can get to the core service of actually reading your emails, not all the bells and whistles of it. And so that's from a resiliency standpoint. And you can learn how your system should react so that you have these great platforms that are very adaptable to all these different changes that are happening. And then it reduces your risk of compromise by using some of those solutions. That's on the resiliency standpoint. And it's a security standpoint is using AI and all the great tools that are out there just to learn behaviors of what is expected out of that particular user or in how we're using those resources, if that makes sense.
Absolutely. I think I'm going to go probably to one of the most complicated questions, and just based on what I've heard today. All these cool things that we've got, there's all cool ideas that we have, this technology that's in front of us, great ideas that you guys have talked about. I think I'm going to give you the hard question now. As it relates to human capital, you're thinking staff, customers, internal and external, even contract organizations. What struggles exist for you in your space, and what steps are you taking to mitigate those, to do all these cool things? And if you've seen any successes, whether in your organization or somewhere else, share those. And we'll start with you this time, Lucas.
All right, thanks. So I guess if you look at all customers and the products that I'm dealing with for the most part, which is the ones I gave, one of the biggest struggles that I have is the ability of, I guess, customization, right? Because customization is directly correlated with, I guess, what's the right word I'm looking for? Being happy with your product, right? If you can customize it to meet your exact need, then you're going to be the happiest with it. And that's from an internal use perspective and from a patient perspective. I was actually at a talk a couple of years ago, and a guy gave a great analogy. He asked how many people in the audience have a smartphone, and everybody raises their hand. And he said, how many people customize their smartphone to be exactly what they want it? It's the home screen they want, it's the apps they want, it's the icons they want, things where they want them. It's completely customized for their use. And he said, what's your, what do you feel like your percentage of happiness is in your phone? And everybody's, in the 90th percentile to 100. Then he said, now I'm going to clear your phone, put it back to factory settings. You can only use it this way. You can't make little customizations. You get it as it's provided, and you have to make it work. Now, how happy are you with your phone? And everybody's like 10%, you can have it, right? So, we deal with the same thing. We're utilizing vendors, and technology is coming out there, which is great. And we're getting solutions that we can use. But maybe this is to your point a little bit, Elbridge, like we're moving fast enough that, okay, so the solution's there, but is it the right solution? And does it have the ability to be customized to meet the demand of the organization or the user and to the patient? so that they can get the most out of it and be the happiest with it. And that's been a tough one, right? Working with the vendors. And I get it, because I'm asking for something that maybe it's just optimal for us, but it might not be for the other 99% of your clients. So it's not worth it for you to invest the capital and the manpower and everything else to create it. But on that same note, we don't have the capacity to build our own solution from scratch.
So you're thinking in meeting the needs of the internal customers, the external customers, and then having the resources to do that work.
Right. It's tough, right? I mean.
Okay, thanks. Thanks, Lucas. Dr. Kluatjy. And I can restate it if you want. There, the focus is human capital. What kind of struggles are you seeing in your space? What are you doing to mitigate those? What successes or positive experience have you seen from that process?
So yeah, it is a tough one. I would say, and I agree with the sorts of things that Lucas pointed out, and part of that, in terms of customization, having things the way you want. I think for us to enhance patient engagement with the healthcare system, and we're talking at any level, whether it's calling into the office, using the electronic medical record, whether it's using technology in the hospital, outside the hospital, and so forth. The issue really is one of trust on the part of the patient. That's actually one of the sort of the key factors, and trying to mobilize that. If you have that, you actually have more than half the battle won. Because if you don't have that, you can stand up whatever solution you want, and I don't think it's going to work very well. The patient, if you want to set up, remote patient monitoring, that patient could just say, no, I don't want to do that. That sounds too fancy. I don't trust that sort of thing. No, they don't trust that. Oh, I hear those things get hacked. Oh, so they don't want to do that. They get worried about all the other information, the other noise out in the world that distracts them from the sorts of things that we want to offer. And so if we're able to have the patient trust to say, look, we have this technology, it's safe, it's secure, your privacy will be honored, you can opt out, it's not like they're being hammered by multiple messages, you can opt out. Come with us on this road in which we are going to help you manage your chronic disease process or self-guide toward getting information. And so whether it's the technology, having the patient trust the system in that regard, or changing patterns of care, right? It used to be, you just had your primary care physician. Then you had your primary care physician and a bunch of specialists. Now, the last jump in the last 10 years was, you're not going to see your specialist, you're going to see a specialist nurse practitioner. And so you have, and I have still patients who don't want to do that. They want to do what they've always done. And if you don't create a scenario where you can expand that trust, and that's true of staff as well, right? We have staff that have been around for a long time, and they're kind of like a little resistant to some of the new technology solutions, but bringing patients and staff along, that way you can actually utilize technology. You can change the way that they consume healthcare. You can change the way they consume healthcare so that they don't just have the expectation, I'm going to go see that doctor at that building. No, maybe it's via telehealth. Maybe it's a doc in the box. Maybe it's a retail solution. Maybe it's a community health center at a kiosk. Maybe, it's a number of different ways. What do patients trust? What and how flexible is staff going to be to mobilize and get on the same plan with respect to that? So real quick, I think with respect to successes, I think I can begin to see one of our director of optimization, Caitlin O'Farrell, has worked really hard with trying to stand up getting my chart solutions get increased signups, right? We're talking about getting patients to trust us. Well, how are you able to do that? Well, it means getting the patient in the office, but it also means marketing. It turns out that in one of our last conversations, that it turns out that NPR radio ads turned out to actually be relatively successful in getting patients to be signed up on MyChart, as opposed to some social media, not as many hits there. So you have to test out, you have to go to where the patients are. And I think that's one of the things that shows me. You may not know the answer. You may actually have to try different things. So that really, Suma has done a decent job of increasing their MyChart signups in that regard.
Dr. Kluatjy, I'll just say real quick, that's a great point. And just to kind of reiterate that home in a real life example, we've had direct-to-consumer and telehealth visits for a few years, right? And the buy-in from the physicians was probably 25%, because the remaining said, I'm not going to be able to, they didn't even want to try it, right? I'm not going to be able to provide quality care over telehealth because I need that patient in front of me. To some almost rejecting it. And you'd have the same thing from patients, right? Especially the elderly. I need to be in that provider's office and seeing them. Well, then they were forced to use it, for lack of better words, with the pandemic, and they had no choice. It was use this solution or don't see your patients, or use a solution, don't see your doctor. And after only a month of utilization, now it's all they want to do, right? Not all, but I mean, so yeah, that's a great point. How do you get buy-in? How do you get trust and buy-in? That's with new solutions.
Thanks, Dr. Kluatjy. Thanks, Lucas. Yeah, I'm sorry, I didn't mean to cut you off there, Lucas. Go ahead.
Nope, that was it.
Thank you. So Jeff, I'll turn it over to you.
Yeah, I mean, for us, as far as people and customers, in the urgent care space, we sit really on the fence between retail and healthcare, which is an interesting spot to be, because we're both engaging with folks from a consumer standpoint, but then also obviously having to deal with our own staff internally. And one of the things that we found is that, especially over the past several months, is that whereas we used to be hiring people locally for a lot of things, we've moved to a more virtual environment. We've even taken some folks where we're using folks around the globe actually to be able to meet some of the demands on capacity and whatnot. And that's posed a lot of different challenges as far as just collaboration with folks. Video conferencing and everything. But also, from a security standpoint, is that, when you've got folks that are working in remote locations where we may not have, robust infrastructure and offices, you've got to, figure out how does that work as far as security. We've actually onboarded a number of vendors, and we've had to go through, a lot of security, evaluations with them. And then, in our unique situation where we have partnerships, we also have to be able to, interact with our partners in a lot of ways as far as how do they look at security, how do we look at security, and how do we agree on what the security protocols should be for remote work and for other things. But the capacity as far as bringing on additional staff and being able to deal with all of the challenges as far as engaging customers in a more in maybe a less direct way in some cases, and being able to do that appropriately and securely has been obviously something that's been on our minds for quite a while.
Thanks, Jeff. Now, what I heard before I go to you, Brad, I know you'll have some comments about this. I'm going to point it out anyway. I'm take a little bit of your thunder. So, what I did hear you guys say, which I was a little surprised too, is a lot around transparency, a lot around trust, a lot around sharing experiences and that sort of thing. And I know those are all the opposite words that Brad would recommend. But I'll turn it over to you, Brad.
I'm with you. I think the more open, and I'm very passionate about this, is that we're all here to solve the same problem, especially when you're looking at it from different vendors. You got your vendors, they're trying to do business with their customers, and there's all these compliance and security questionnaires. And a lot of times it's just a kind of a battle back and forth with who's right, who's wrong, but it's really everybody's trying to solve the same problem. And I think that's a huge downfall of some of the things with compliance is when are we going to when are we going to almost reward and incentivize people to be more transparent? Because the more transparency you do have in the cybersecurity space, the easier we can take action. I mean, that's evident by the executive order out of the White House about how do we make sharing of data more out there, so that it's not an us versus them mentality. It's how can we come to the right answer and solve that problem? And because that's just sheer complexity. There's a study, this is about, I think, 15 years ago, where it looked at the velocity of code that's being developed. And, obviously linear, the more code you build, the more bugs you're going to have. And the more bugs you're going to have, the more vulnerabilities you're going to have. But it was linear with the more code you built, the more bugs you're going to have, but it was actually exponential in terms of the vulnerabilities. And that's why we're seeing just a huge exponential growth in code, but also an even more exponential growth in vulnerabilities. And you can't, you used to be able to handle that within your own organization, but you can't anymore. And that's why that sharing of data really needs to be out there. And so I encourage the sharing and transparency of data and information, because I think everybody's going to be better for it. And then on the human side, I talked about compliance automation that helps kind of drive the efficiency with that. But then there's a shortage apparently in cybersecurity with skills. And I think what we're trying to do is widen the net of where we're getting the talent, and not just putting on a job description that you've got to have 15 plus years of experience and have to know have all these certifications and have all these qualifications just to enter the cybersecurity marketplace. And so how can we widen the net and have things like apprentice programs, or look out beyond just the traditional college education, look at some micro credentials and things like that, so that we can widen the net and really diversify the ideas that are out there. So it's not just a traditional path to cybersecurity. So that's how we're addressing, that problem. And I, would encourage others to think that way as well.
Thank you, Brad. So we're down to our last 3 minutes or so. So I'm going to ask this last question, and just take about 30 seconds each, if you don't mind. And we'll go Dr. Kluatjy, Lucas, Jeff, and Brad. So given everything you heard today and given where we are, what recommendations do you have for healthcare leaders? Dr. Kluatjy?
I think first I would have healthcare leaders focus on the talent that they have existing. Yes, there are going to be holes, but try to create a situation in which people are not siloed. Create a situation in which people can work collaboratively to solve problems. Then I would also look out there, think outside the box. That the old solutions have a role to play, but newer solutions are really going to be in the forefront. So flexibility is going to be high on the list. And then the other point that I mentioned is that you can come up with any great solution that you want, but most of the time it is probably not going to work unless you get buy-in and you have trust of both the patients that you're trying to take care of and the staff that you're trying to implement those changes.
Go ahead, Lucas. You can go.
Okay. So I think I kind of wrapped this up in my presentation as well, and just think outside the box. Don't always look at what you've done in the past. Be creative. Try to, think of how you can utilize, whether it's people, technology, whatever. Don't get stuck with what you've done before. Think outside the box. Be creative. Get teams together. Brainstorm. Find the best way to meet your need, and to create that opportunity, not just the way you've done it in the past.
Thank you. Jeff?
Yeah, I think that, as far as recommendations, think people have to be flexible. I mean, clearly with changing times, there's sometimes priorities that are changing, and in healthcare sometimes it seems like there's been, the status quo is an easy path in a lot of ways. I think people get in routines and whatnot. I think the pandemic and some other stuff has really given healthcare sort of a shakeup as far as what needs to get done. And from a leadership standpoint, being able to change direction and pivot and find out what are the needs of the communities that we all serve, and be able to meet them where they are, because a lot of times it's not easy to be able to understand exactly what patients expect or communities expect from the healthcare facilities that they're in or that they're in. And I think you've got to be able to listen and be able to get feedback and understand how you need to organize teams and how you need to prioritize to be able to meet those needs. Because at least I've learned that you have to be able to evaluate the current situation and try to plan as best you can to go forward, but you may need to change plans depending on what the needs are.
Looks like we might have lost Elbridge, but I guess I'll go next. I agree with what all you guys are saying about just thinking differently, thinking outside the box, and specifically to technology and cybersecurity behind the scenes. This is really a message to what I would recommend to healthcare IT leaders is that the cloud is no longer emerging tech. It's here. There's a great migration going on in the enterprise, and there's even other emerging technologies that we've talked about. But as we're moving these legacy systems to a cloud environment, don't think of it, talk about thinking outside the box. It's not just a lift and shift mentality. Don't take your Oracle database and create another Oracle database in an AWS environment. Use the native tools that are out there, and that'll help you reduce all the technical debt that's out there. AWS has the 6 R's, they call it, refactoring, repurpose, rehost, relocate, et cetera. You can look through that guidance and take it to heart and really, really consider the refactoring piece of that to just take what you need and put it over versus taking what you have and putting everything over to get the most benefit. So who wants to moderate now?
I think Elbridge and Christine are working behind the scenes to get a 5th person in. I think that's my understanding. The current structure, I think, limits the ability of someone else to share the screen if there are 5 people who are on. At least that's my understanding. So I think we have to be patient.
Okay.
All right, guys, this is Clay filling in for Chris. I'm waiting for her to be able to join, but I think that we're in a good place. So I think that Elbridge was able to answer or get all of his questions out there. So I think we can move forward and move towards closing out the presentation for today. Did you guys have any last final comments that you wanted to go bring up before we closed out for the day?
I didn't have anything other than just thanking everybody for having me. It was a pleasure.
Same here. Nothing to add, but thank you very much.
Yeah, we cannot thank you guys enough for your time today and the expertise that you brought to the table. We're very thankful for it, and we will let you all go. Thank you so much.
All right. Thank you.
And we'll give it 1 second here for everybody else as we try to close out the event today. I want to make sure that Chris has a moment to be able to close out the event. So just give us about 3 minutes here, and we'll turn it back over to her. And if not, I'll go ahead and do it for her. Thank you, everybody.